Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. You check box.
This is Papa Smurf.
I haven't been taking care of the patient for 4 days, but it's fine.
These two aren't bitter at all.
During-
This guy's a hot mess, isn't he?
No, actually, this
That
is
is a typical
it's a stable.
patient. I forgot to write all this down. Will you repeat it again?
Oh my God, I hate you. Welcome to the Fresh RN podcast. I am Katie Kleber.
Hey guys, my name is Elizabeth Mills.
We're going to talk about report.
It's a little.
Let's start over.
No, it's okay. Let's keep going.
Okay. All right. So this is an episode about report, and report is kind of challenging as a new nurse because it is kind of something really important to do and be good at, but it takes some time. And
Be efficient, organized, and get your point across.
Right. And sometimes you can work your butt off all day, and when you're giving report, you're like, it sounds like I did nothing today.
Right. But you really did.
But
guys.
you did so
You
many
worked hard.
things. All right. And okay, I want to jump right in and talk about report between nurses on one unit. So ICU to ICU, ED to ED, floor to floor. That looks very different than me in the ICU getting report from the ED
Right.
versus giving report to the floor.
Right.
Your expectations should be different.
Yeah.
The ED nurse is not worried about the same things that the ICU nurse is worried about, and that's the way it is. I can't hate on that ED nurse for not giving me this meticulous skin assessment because they cared more about intubating my patient who was having a massive stroke. So the ED report should be they only do focused assessments. I don't want to say only. They do focused assessments because that's what they need to do. So their report to you should look very different. And then the report that you're going to give to your fellow ICU nurse, if that makes sense. So just because it's different doesn't mean it's bad. And when you're giving, as an ICU nurse, if you're giving report to the floor, there's things you may be giving them report on that they don't really care that much about. Like they don't care that their patient was on Neo yesterday. Like they don't deal with Neo and that's not a thing to them.
Right.
So like I remember when I used to get a report from the ICU of a patient coming from the cardiac ICU to my floor, I want to know their arterial line was discontinued this morning, but I don't care that they were on a little bit of Neo yesterday.
Right.
Like that kind of stuff. So having realistic expectations. But let's talk about a little bit of etiquette. Okay, there's kind of like unwritten rules, I feel like, with report. And the number one is, let me just tell you the basic format. So if I'm giving Elizabeth report, Elizabeth, I'm leaving, and Elizabeth is coming on. I'm going to say, this is, Mr. Smith, and I'm going to go through my report. And I am going to talk. Elizabeth is not going to ask questions in the order in which she wants to receive the information. That's not how report functions. It's, I'm giving you report, and I'm going in a systematic head-to-toe kind of way. It's not, what is the patient's name? What is their diagnosis? What is this? What is this? Like, that's just not, it's a very inefficient way to go about doing things. And the off-going nurse gives report. And then the oncoming nurse receives it and then asks clarifying questions, but doesn't constantly interject with questions.
Right.
That is my pet peeve. I am so mad at you if I call to give you report and all you do is ask me questions.
You know what? There's nothing wrong with saying, you know what? Can you hold off questions till I'm done?
Yeah. Because I was gonna answer that question before you interrupted me.
Yeah. For the 16th time.
Y'all, this makes me so hypertensive when people do this.
Sometimes I get to the point where I'm like, hey, you just want to ask me questions and I'll just answer?
Right.
I'll quit talking.
I will stop. I haven't been taking care of this patient for 4 days, but it's fine.
These two aren't bitter at all. Not even a little bit.
So anyways, that's kind of like report etiquette, I guess. So it's my job to paint a clinical picture for you. It's not my job to make sure all of your little check boxes are on your report sheet. Check boxes. You check boxes. So I don't some people get so inundated with getting all of the little boxes on their report sheet filled out that they forget about, okay, I'm painting a clinical picture for you. Okay. And one of the things is also, I don't need to utilize report to tell you every little thing you can read off of the chart. I'm going to tell you pertinent history. I'm not going through their entire medical history. There's various things like what IV do they have? I could spout that off to you real quick, but you can clearly see that in the chart. Those kinds of things. So don't get so inundated with like every little box is what I want to say, I guess. And report kind of looks at, people give report with a little bit of a different style, but the more concise, to the point, and organized you can give it, the better, I guess. That makes sense. And finally, don't be a jerk.
Right. And asking questions, interrupting is kind of being a jerk, but don't be hard on, don't be like, did you do this? Did you do this? What do you mean?
Why isn't this done?
Right.
And saying it in that tone. God,
Right.
I hate that.
You can say, hey, I see that the patient needed needed a Fleet's enema given this morning. Did you give it? Oh, why not?
Yeah. Like using that kind of like inquisitive tone as opposed to a
okay.
demeaning tone, I guess. And there's things that, if you're getting report and the previous nurse has left all of your IV fluid bags dry.
Oh, yeah, that's rude.
Just say, hey, can you hang new bags before you leave?
Right.
Like in a very business matter of fact, hey, can you get this before you leave? Because that's truly someone's responsibility to make sure that you're situated with medication. So the first thing you do isn't switch out a whole bunch of bags.
Yeah. Good point.
Yeah, nursing is a continual process, so it's important to do that. And also understand that sometimes there are some things that, yeah, maybe it should have been done an hour ago, but I have been off the floor with my other patient in MRI. Like those kinds of things. Like not everything is perfect, I guess.
No, it's not. And it's a continuing shift. It's
Exactly.
24 hours a day.
A continual process. So let me go through a very general, incredibly general list of things that it'll vary if you're on a specialized unit, but these are just some basics that are really important, and I think it's helpful to go through it in this specific order. I'm going to go through this, and then Elizabeth is going to give me a report on a patient. I'm going to give her a report on a patient, so you can just kind of hear how we talk, I guess.
Yep.
And then ask clarifying questions.
And as new nurses, guys, a report sheet to standardize report is really, I think, awesome. You should use it because it helps you to give an organized report.
Mm-hmm. Yeah, and when you're figuring out, it took me a little while to figure out which report sheet I liked the best. But I want to encourage you, if you're trying to figure that out, don't try one shift and then try the new one the next shift. Give each report sheet a few days before you get rid of it. Because you can't really judge if you don't really know exactly where the boxes are and can't do, you know what I mean? Like that kind of stuff. All right, so things to write down when you're getting report. Number 1, the patient's name, physician's code status, and allergies. Top of the page. And whenever I give report and receive report, I really want those to be the top things. Name, physician's, code status, allergies. Next thing, if there's any precautions, fall, seizure, infection ones are big ones, or bleeding precautions. Those are big ones. The next thing is a chief complaint / why is this patient in the hospital, and what are the important things that have happened in the admission? Notice I said important, not every little thing.
Right.
I don't care if they got 2 units of blood 4 days ago, guys. I don't care. But if they came in and they were found down and we figured out they were in atrial fibrillation, and then we found out that they needed a emergent coronary artery bypass graft, I want to know that. And I want to know that they had, they harvested the, saphenous vein or whatever. Like, I want to know those things, but I don't care that they got 2 units of blood right after the OR. Next thing, pertinent history. It will take time for you to kind of figure out what's pertinent and what's not, so don't get super hung up on this. You'll figure it out with time and also shorthand abbreviations for history. So like I would get in report, the patients had a mitral valve replacement. Okay, MVR. Like that's what I would write on my sheet, but at the beginning I was like, mitral valve replacement, but MVR, those kinds of things. Next thing, abnormal assessment findings. So don't waste your time writing down or verbalizing, respiratory system is normal. Like, okay, like that's great, but tell me the abnormals.
Mm-hmm.
And don't waste the time going through each body system telling me, lungs are clear, the bowel sounds are active, heart sounds are good. Like, I don't care if they're good, I care if they're bad, I guess, if that makes sense.
Mm-hmm.
Next thing, if they're on oxygen, how much and via which delivery method? Nasal cannula, face masks, non-rebreather, and has this changed recently? That's a big thing to know. Any tubes, feeding tubes, Foley catheter, rectal tube, all that stuff, and kind of important things to go with that. Like, where is the Dobhoff tube taped at? Those kinds of things. And where is it at? Is it in the duodenum or is it in the stomach? Those kinds of things. IV access is helpful to know, but you can also look that up in the chart. What IVs, if they have a central line, if they have a port. Next thing, IV fluids or drips, basically anything continuously infusing. Normal saline at 125 an hour versus maybe they've got Levofed at 5 or whatever. What's their activity level? Can they have you gotten the patient up? How did that go? Like, can I get them up by myself, or do I need to grab a coworker to help me get them out of bed? I'd love to know that, like, straight from a nurse and not looking in the chart. Pertinent or abnormal labs, questions to ask the physician or other members of the healthcare team that the previous nurse had. Maybe I'll have my own, but things to clarify. Working on day shift, a lot of times the night shift nurse will say, hey, I was looking at the chart and I noticed blank. It wasn't really something to justify calling the physician for, but when they round, maybe you can ask him about this. Okay, great. I'll write that down. Last couple things, any psychosocial or family support system issues or concerns, those kinds of things. And then finally, last couple things, any important meds. Yes, you can look that up, but if there's any concerning or kind of medication issues, if there's any pending tests, procedures, or transfers that need to occur during the shift, like, hey, just so you know, this patient's got a CT at 10 a.m., like those kinds of things. And then general discharge plan stuff. So what are our goals kind of for the shift? And how are we progressing towards discharge? So, yeah, we need them to get out of bed 3 times today, and we need them to pass their swallow evaluation, and then hopefully they're going to get out of the ICU today. Like, those kinds of things to be communicated, because I can't quickly pick that out of the chart. So that is some important stuff to communicate in report.
Very good. I kind of do a more system-by-system approach, but I usually address all of these problems.
Yeah, and
issues.
I put
tips, points, whatever.
Yeah, I put like the abnormal assessment findings, and you can do that per system. So like neuro, you can start there and kind of work your way down the body, I guess, would be, So yeah.
All right, should we do a sample report?
Yeah, you want me to go first? Or you want to go first?
You go first.
All right, so, and I'm doing this off the top of my head, y'all, so if some things don't make sense, that's okay. But I just want you to get used to the flow of how report goes. Good morning, Elizabeth. How are you?
I'm here.
Oh my God, this is so
I'm
real.
so excited to be here and take excellent care of my patients.
No, that first part was so real. Yes. All right, so this is Mr. Smith. He has Mr. Smith, and I'm gonna. His doctor is Dr. Johnson, is his attending, and cardiology was consulted. He is a full code, and he has no allergies. He is on fall precautions, and he is on contact precautions for MRSA. He is here because he had a stroke. Basically, he was suddenly dizzy at home, didn't have a fall or anything, came in, did a CT scan, found a big old stroke in the posterior circulation. It's actually kind of large, a couple centimeters, kind of right in that occipital region. Found out also pertinent history-wise, he's got a history of AFib. He was on Coumadin, but his INR was subtherapeutic. He also has a mechanical heart valve. He's had multiple ablations in the past, and he has hyperlipidemia, hypertension, and a history of congestive heart failure, although he's not in congestive heart failure right now, but he's got a history of it. So he takes some Lasix and takes some Coumadin at home.
This guy's a hot mess, isn't he?
No, actually, this
is a typical patient in our world.
That's a very stable patient.
All right. Carry on.
I know, right? So
just wait till you. Okay.
Yeah. So abnormal. Okay. So basically, neurologically, he is. Other than he's got some dysmetria and ataxia on the left side, with both the left arm and the left leg. Other than that, he's neurologically intact. And it has been pretty consistent. Oh, that and adding some dizziness on top of that when he gets up, but he actually walks just fine. You can hear the mechanical click when you're auscultating the heart sounds. And he is not on oxygen. No real respiratory issues, but it is a little, he's getting some IV fluid. So, I would be kind of concerned about some heart failure developing, but right now we're good. And the chest x-ray was clear. Let's see, like I said, he's got the ataxia and dysmetria on the left side. He's got a he's got a number 18 in the right AC and a number 20 in the right lower arm. He's got normal saline at 175. Room air, no issue with that. He is voiding in the urinal. And he's a 2 assist. He is in AFib controlled with a heart rate of about the 70s. Obviously, we've stopped our Coumadin. He is on Coreg and Lasix orally. And let's see. Labs were pretty good. INR was 1.2. Let's see. Ask the physician, hey, I think we need a PT-OT consult. They actually haven't been consulted yet, so I think it'd probably be a good idea to chat with them.
Okay.
Yeah. And then family, everything, nothing kind of odd with the family, really. Patient seems to be doing okay. And hopefully getting out of the ICU today and transferring to the floor and maybe home in a day or two.
Okay. I forgot to write all this down. Will you repeat it again?
Oh, my God, I hate you. So that's kind of report.
That's a good report. I think that took like 2 minutes, literally.
Sweet.
All right.
So that's how I would have given report on somebody. Notice, I didn't go through every single body system. I just went through the abnormal kind of things. And yeah, I'm sure there are little things here and there, but I don't know. And normally what we would do is she would do a quick neuro assessment and notice if he still had the ataxia and dysmetria on the left side.
Yeah. And it's good because we have the chart open at the bedside too. So we kind of, that's why bedside reporting, some people don't like it. I think it's great.
Yeah.
All right. So I'm going to give you a report on my patient. This is Papa Smurf.
Oh, I love Papa Smurf.
He's a 115-year-old gentleman. Patient.
Code blue.
Just wait.
The definition of a code blue.
He is a patient of Dr. Sam's stethoscope.
Y'all, Sam's stethoscope is the default name in our playground, epic training thing.
He's got allergies to sulfa and wildflowers. Anyway, so this young gentleman came in with urosepsis. He lives in a skilled nursing facility and was found unresponsive. Came in through the ED, blood pressure was 60/40.
Oh,
lactic acid was 6.
Oh, Jesus.
Got diagnosed with urosepsis. He got 3 liters of fluid in the emergency room, got lined, and got placed on pressors, and was brought to the ICU. Neurologically, he's confused, generalized weakness, but follows commands. He's attempted to get out of bed a couple times, so he's had to be put in restraints. He denies pain. He's not gotten anything for sedation or any pain medicine. Cardiac-wise, he's been sinus tach in the 120s. He came into the ED. His heart rate was in the 150s, so he's coming down.
Nice.
His pulses, you have to use the Doppler. So he's got decreased circulation. Oh, past medical history. I forgot to give you that. Has a past medical history of hypertension, cyanotic skin disease, and...
Papa Smurf, no way.
And dwarfism. I'm just kidding.
That was beautiful.
Anyway, so back to his cardiac status. So our goal is to keep his MAP greater than 60, and he's currently on some Levophed at 10 mics, vasopressin at 0.04 units an hour to keep his blood pressure over 60. And you see right now he's like 95/50 with a MAP of 62, 63.
Nice.
Pulmonary-wise, lungs are a little coarse. He is on 4 liters to keep his stats greater than 92, and that's been maintaining. GI, he's NPO. He's got a OG or NG tube taped at 65 to low wall suction. He had some vomiting upon arrival to the emergency room, so he's got an NG tube in. We are checking blood sugars every 6 hours. He's got a Foley catheter. His urine output, he's only put out about 15 cc's in the last 2 hours, so we're having to keep a close eye on his urine output. IV-wise, he's got a right triple lumen IJ. Fluids are normal saline at 150, and then you have your Levophed and vasopressin going in that other port. What else can I tell you? Lab. So his white count was 19. His hemoglobin is currently 8. Last lactic acid was 4, so we're trending down. Potassium was 3.1, so he got some potassium replacement a little while ago. The next of kin is his daughter, Drielle. And Gargamel is the password. So we set up a password with family members who want to call and get updates over the phone. This is going off topic, but anyway, so that's what the password means. Skin-wise, he's just skin is dry. It's blue. But he's got no skin breakdown. He's just got poor skin turgor because he's so dehydrated.
And blue.
So the plan is we're going to continue pressors, monitoring his lactic acid levels. We'll repeat labs in a few hours. To try to get this sepsis resolved. He is on Cipro and Vanc for his UTI. Mm-hmm. I don't know if those are the right antibiotics. So vancomycin is usually one of them.
Yeah.
And then see where we go. So he's going to be here in the ICU for at least another 12 hours. PT, OT haven't been ordered, but they should probably be looked at tomorrow if he's able to wean off pressors.
Wonderful. What are your, my only question is our DVT prophylaxis, I guess.
He's on heparin sub-Q and SCDs.
Wonderful.
I think that's about it.
Yeah, and see, like, the thing is report's not going to be perfect. You're going to forget stuff. You're not going to do it perfect every time. You're going to say, okay, what am I forgetting? And one of the things I always do after I'm finished giving a report is say, what did I not tell you? Mm-hmm. So the person can tell me, oh, wait, I actually have a question about blank. So I think that's important to do. You're not going to give it perfectly. There will be days when you kind of like worked your butt off to give a great report and then you feel like you like did nothing, you know?
Was Drielle the Smurf, the lady Smurf?
I have no idea.
I never watched Smurfs.
I haven't either.
I find it fascinating that you are such a laureate at Smurfism.
I don't know why I picked Papa
history
Smurf.
of Smurfism?
Smurfdom, yeah, the kingdom of the Smurfs.
It's kind of cyanotic skin disease.
That was pretty good. I did not get that cool creative with mine. Dang it. So, there's going to be days where you feel like you did a ton and then you give a report and you did nothing. But I encourage you, make sure you get a good report sheet that you like and stick to it, and give it a few days before you switch to another one if you think you don't like it. I'm going to put a link to a little brain sheet database where you can download 34 different ones and pick one that you like. They look different for different specialties. And you'll be able to give and get report a lot faster once you get your sheet kind of memorized. I've actually gotten to a point where I have the neuro ICU one memorized, so I just use a blank sheet of paper now. But the link I'll put in there is free database. So you can just kind of check it out and see what you like. So that's report. Yeah. Thank you guys so much for listening. Check out freshrn.com/podcast for this fun little database and some additional little notes about giving report. You'll get better at it, I promise. Also go to freshrn.com for more fun resources and gear and all that good stuff. And stay fresh, guys.
Been listening to Smooth Jazz 102.7. Coming up next, a brand new band,
that's
Papa Smurf and the Nurses.
Radio station in Wilmington. That's 102.7.
But Papa Smurf and the Nurses.
Papa Smurf and Michelangelo are going to go share some pizza.
With, what's her name?
It's not. What is the girl? It's not. Is it
Delphi?
Drielle? It's Drielle.
Drielle.
Is that the female Smurf? Let's Google.
Okay. I'll be Michelangelo. You can be Papa Smurf. And you can be whatever this person's name is. With your cyanotic skin disease. All right. We digress. All right. Thank you guys so much for listening and stay fresh.
Damn girl better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat that'll make you scream. I don't believe in playing it safe. I got the urge to misbehave. I've been known